everyone. Welcome to another episode of Beyond the Benefits. I'm your host, Zoe Kobrin, joined by our co-host here, Mark DeFee. We're happy to have you back. Today, we're going to be talking about some terms that get thrown around frequently in the EAP world. And even though probably familiar with them, we thought it would be helpful just to take a bit of a deeper dive, really help you able to sound more like a pro in terms of some of the questions that you ask when these terms come up in meetings. So, Mark, how are you?
I'm good. Yeah. And Zoe, I think before that, I was thinking about how whenever I'm out, like in public or a party or whatever, and someone asks, "Oh, what do you do?" I'm in the EAP field. When you say that to people, how many of them actually know what even EAP means?
Yeah, well, it's funny because I usually, before they can even ask, I usually say, "Oh, I work for an EAP. Are you familiar with employee assistance programs?" Yep. And usually the answer is no, or they say, "Oh, do you hire people? Like, do you do staffing?" Yeah.
Getting back on track, because you're right. Besides just the term EAP, there's a number of other ones out there. So, Zoe, where do you want to start? Where are we starting?
Well, I thought it might make sense to start with just with the most basic, which is how we tend to refer to people who use the EAP. And instead of saying employee, we say member. And part of the reason is that, we really do we serve many more people than just employees. Some EAPs will serve immediate family members as well, or household members. CCI actually takes an even broader view in really anyone who's having a direct impact on the employee's life, whether that's an extended family member, a roommate, a neighbor. We want to be able to support them as well.
Yeah.
So we refer to members as opposed to employees.
And that is an important distinction, because some EAPs require a file feed, an eligibility feed, or some type of verification of employment. And that's just a barrier to care. And one thing I love about CCA is I've seen, the term over and over with us, like family. So if someone is like family to your employee, then they're a member to us. And I think that's really cool. So that's what benefits consultants need to be thinking about when they hear the term member. How broad is it? And why does an EAP choose that approach?
Yeah. And I think along those lines, Mark, another good question to ask is, how does the EAP handle it if someone calls in and they maybe can't find the client company they're affiliated with in the system? CPA has a just serve first policy. So we are always going to provide support and then try to figure it out later. There's not much worse than someone, taking that initiative to make the call and then to be turned away. So that's a really important question to ask is, how are the intake counselors or representatives, whoever is answering the phone, how are they trained to handle those situations?
Such a good point, especially when organizations have multiple subsidiaries.
Right.
Employees might not know the actual account name put in the system, and turning them away saying, "Well, go ask HR," anything like that is going to stop them oftentimes from seeking out support. So that service first approach has to be in there if an EAP is going to say they're best in class.
Exactly.
All right, Zoe, where are we heading from here?
Well, during that initial intake, and, we had just talked about how, it might be a customer service representative answering the phone. And with CCA, it's always a live master's level counselor. But that's also a good question to ask. How many steps does someone need to go through before they are connected with a counselor who's going to complete the intake assessment? And during the intake assessment, what types of assessments are being used? We use a variation of the PHQ-9 and GAD-7. And so do you want to speak a little bit to the PHQ-9, Mark?
Sure. The PHQ-9 patient health questionnaire, it's 9 questions. It's a validated screening tool focused on depression. And the PHQ-2 is just a shortened version of that. The biggest reason just being the time it takes to answer all 9 questions, knowing members might not want to do all that, but we need some type of data from them. So the PHQ-2 is often used on those initial assessments with members.
Yeah.
But there's another one out there, Zoe.
Yeah. And GAD, generalized anxiety, sort of the GAD-7 is the full complete version of that assessment. But just as Mark mentioned, sometimes people don't want to take the time to answer all those questions. And sometimes it's clear that it's not necessary, right? And so in those cases, we would just use the GAD-2, just the shorter version. This is an important question to ask as well. Our intake counselors don't have any time limits placed on their calls. So if someone's in distress and they need to be on the phone for an hour, providing that in the moment support, that they can do that. If it's a lengthier assessment, that's absolutely fine. But our counselors are very savvy and intuitive. And if someone makes it clear, they just want some couples counseling, they're going through a divorce, and they're not showing any other risk signs, they don't want to complete the full length of the assessments, we are going to meet them where they are. So I think, and then likewise, if someone says that they've been drinking as a way to manage their stress, then the counselor will know to move into an assessment that specifically looks at, alcohol use, drug use. So it's not just a script. It's really sensitive and responsive to how the member is answering questions.
Yeah, in that clinical only answer model, I think is huge again to knock down a barrier to care. But you brought up something in terms of those clinicians making judgment calls of how much needs to be assessed. One caveat I'll say, and Zoe, we're both clinicians, you know this. On every call, we do need to ask about 2 areas. The first one, are you currently having any thoughts of wanting to harm yourself or anybody else? And then the second one, do you currently have any knowledge about child abuse or elder abuse occurring? Like those are 2 things that, regardless of the situation, often need to be asked so a clinician can verify that they're assessing for the most concerning matters that typically require a breach of confidentiality. Not typically require, but sometimes require a breach of confidentiality because someone's in danger of themselves or someone else.
Yeah. Yes. Good point, Mark.
Well, and I say that because so many members would get frustrated or why are you asking me that type of question? I'm not suicidal. Okay, I get it. But as a clinician, we're required to check that.
Yep. Yeah. That's a standard part of any EAP intake call.
Yeah. Yeah. I will say, like probably everyone else out here in this world, having to repeat my answers to questions like that are kind of frustrating. So again, the clinical only answer model, so you're talking to one person the entire time, makes a difference.
It does. It does. And, you mentioned kind of repeating answers. You know, People only have to answer questions once during our intakes. But the questions that they have answered from the PHQ and GAD, just depending on the length of the assessment they took, those are repeated usually midway through their EAP sessions, should they pursue counseling through us. And then upon completion of sessions, and this is really important because it gives us a sense of how effective their counseling is, as well as whether they still have any unresolved issues or needs at the end of treatment, so that we can make sure that they are getting all of their needs met.
Yeah. Crucial. You can't evaluate something you don't measure, I guess.
That's right. Yeah, and that's how we're really able to see improvement, and also to just keep tabs on our provider efficacy. So it's those outcome measures are very important.
That's a great point about that last one, provider efficacy. It's going to help us understand which provider is helping people make movement the most.
Yes.
So, what should EAPs do with those outcomes?
I mean, I think that outcomes are only as helpful as what EAPs do with them, right? So if outcomes aren't great, then that means we need to take a step back and look at our providers, look at the types of treatment that they're using. We need to look at, the members and how many sessions they're attending, really to take a deeper dive and see, why aren't we having better outcomes here?
Yeah. Yeah. I totally agree with that. We have to be looking at it, measuring it if we're truly going to be a customized solution for specific organizations.
Absolutely. And that's kind of a nice segue into if maybe want to jump to talking a little bit about return on investment or, value investment.
Sure.
um, and terms that come up a lot. So ROI, VOI, return on investment does speak more to the dollar amount. So, how much are we saving by people being able to get support through the EAP and not have to dip into their, behavioral health benefits? How much are we maybe preventing people from going to the emergency room, right? Because they're talking to one of our counselors and getting that in the moment support. How much are we reducing absences, right? Time off of work for people needing to deal with some of these personal things. So that would all feed into the return on investment, right? Your ROI. The value, the VOI, is really more some of those things that you can't quantify. You maybe can't put a dollar amount to them, like, employee morale, right? A culture of well-being within the workplace. Um, Sometimes you can't always quantify productivity, right? Or how well people are, strengthening relationships between team members. Mark, anything you want to add to that?
Well, I mean, you're right on. There are certain things that can be quantifiable under the return on investment, and there's still things to consider there too. I believe I can't remember who this was. I think Mark Atridge, one of the well-known EAP researchers out there, and he talked about with return on investment being very careful when organizations can say they can reduce it so much year by year because they're typically comparing it to a variable number as well. So they might say, well, your behavioral health claims are going to go by down by this much next year. However, next year they could have 4 people go inpatient. That skyrockets that behavioral health number. Like it's tricky, is my point. It doesn't mean that these numbers are misleading or wrong or anything, but it's being compared against another variable number that EAPs might not have much influence on, but could absolutely be impacting the return on investment. And that's why the value on investment is so important, accepting that there are things in our world that we can't quantify. And so there are things even in the business world. I know in corporate America for sure, we want to be able to point it back to a graph, saying we've gone up or we've gone down or whatever. But there are certain things that we need to just use kind of logic and common sense that if they feel more connected to their coworkers, they're probably going to, perform at a higher level. If they appreciate the relationship with their direct manager more, it's going to improve their mental health. And again, going back to performing at a higher level. And so being able to move beyond just the quantifiable dollars and cents is where organizations really start making an impact on workplace mental health.
Yes.
One thing I will toss in there, and this is kind of going back to how terms are used differently sometimes in the EAP field. You might also hear ROI as release of information because that's a big one in the EAP field, especially if we're reporting back to an organization. We need to have that signed release of information from a member before we can do anything like that.
That's a good point. Yeah, and I guess, typically when we're talking about an ROI, most often has to do with a formal referral. This is another one where there are many different terms that mean the same thing. So
Yes.
typically it's a formal referral, but sometimes it's called a manager referral, supervisory referral, sometimes mandated referral, although I think that one is sort of fading away.
Yeah. Yeah. It's a little outdated saying mandated.
Yeah, but essentially, this is when typically there's some sort of performance issue and the employer makes a formal referral in an effort to give an employee the opportunity to address whatever might be going on in their personal life that's impacting their performance at work. Very often, sometimes substance abuse is involved, their mental health issues. So it's it really is an opportunity for them to get some support in working through that. But in order for the EAP to be able to share just very basic information, yes, they made contact, they're complying with our recommendations. We need that signed release of information.
We do. Yeah. And you're right about all the terms for the formal referrals. And different EAPs say it differently, but being able to understand you have a referral level where the company will receive limited feedback. That we're not going to tell a company what someone said in their counseling session, but we'll tell them that they attended and they're working on the issues that have been asked to be addressed. Typically, a referral like that starts with what's often classified as an informal referral. So our consultants will work with managers who are sitting there going, I know someone's struggling. I saw them crying at their desk. They didn't want to talk about it, but I know they're going through a hard time. And it might start with, hey, Zoe, I'm concerned about you. I just want to remind you the EAP is here and I'm not going to, find out anything about it. It's confidential, but I really hope you take advantage of it. And that's typically like a soft place to start. But maybe in a few weeks, if nothing's changed, that's when the manager goes to them saying, hey, we need you to improve your work performance back to the level that it was. And at this point, because it's been going on and we haven't seen a change, we're going to ask that you sign this release of information and work with a professional to help you get back on track because we know you're a good employee and we've seen great things from you and we want to help you get back to that level. But at this point, we need to know that you're doing something to get there.
Yeah, exactly. And, this might also be a good time to talk about fitness for duty. This is, or FFDs, right? Sometimes these are also confused with formal referrals, or like return to work clearance. Typically, fitness for duty really, just refers to whether or not someone is able to perform their job responsibilities. And sometimes that might mean physically able, mentally able. And in the case of a forensic fitness for duty, that's when typically there's a safety sensitive position, or maybe someone has been using substances, or there's a mental health issue that's really impacted their ability to function at their job. Um, that would be a forensic fitness for duty, where it really requires what we call independent medical evaluators, psychiatrists, medical doctors who can do an assessment and decide whether or not someone is safe to return to the workplace. Um, those are typically fee for service. I know that at CCA, it's just a pass through cost. It's not something that's marked up, but it is fee for service. And that is very different than you know, um, a formal referral where one of our counselors is able to say, as far as we can see, this person, is able to return to work. They've met their goals. It's different than that very safety sensitive
Yeah.
need. Mark,
Yeah.
yeah, that's that.
And a few other comments, because you're right, like a formal referral, supervisor referral, whatever you want to call them, that's usually making a determination of right now. At the end of our final session, there is nothing we can see that is causing us concern. Whereas a fitness for duty evaluation is more of a future determination. You are paying for, like Zoe said, a medical professional, typically a forensic psychiatrist, to make a determination this person is going to be safe or unsafe in the future based on X, Y, and Z. And one thing that also fitness for duty forensic evaluations are used for like threats of violence. One of the bigger reasons you do one is because that medical professional puts together a legally defensible document that if something were to happen in the future, that a company can point back to saying, we followed best practices and these are what the professionals told us that they could determine. And the last thing I'll say on fitness for duties, you always want to pay for them as the employer, because if the employee pays for it, they own the results and they don't actually have to share them with the company. But when the company pays for them, you can get that release of information signed. Also, there are a couple $1,000s, and typically I tell an account, if you're paying for one, you might need to get ready to pay for three, because there's a chance that employee is going to say, I want a second opinion. And then you're going to need a third one to be kind of that tiebreaker. So it gets very complicated with these fitness for duties. And we don't expect benefits consultants to remember every single thing we're saying, but we hope you remember to parcel that out when you're asking EAPs about it. How do they handle these cases and why do they take the approaches they do? The last terminology, let's talk about critical incident responses versus critical incident stress debriefings. What's the difference? When would we use them? Um, Zoe, what are your thoughts on this term?
Yeah, I've also heard, CISM, right? Critical
Yes,
incident stress
that's a yep.
management. And essentially they're really all the same thing. It's a specialized response to anything that has impacted a group of people in the workplace. And I have to sometimes people will ask, well, what qualifies as a critical incident? And the answer is it's really anything that, again, that has a significant effect on employees. Most commonly we see critical incident response requested after, there's an employee has died, there's been some kind of accident or traumatic event at the workplace, sometimes major weather events.
Mm.
But essentially we are sending someone on site or doing it virtually, but the provider is trained in crisis response. And most commonly, what they do is do a group debriefing. So, meeting with the group of employees who are directly impacted, helping them process, and then usually being free to meet with people one on one if they'd like to do that. It doesn't always have to follow that format. It could be a combination or one or the other, but that's essentially it. It's a response to something that has impacted the workforce. And again, I think some of the important questions here are, what kind of trainings do the providers have? How quickly can you have someone on site? Do you have coverage, in all of the different locations? And do you have a minimum? That's sometimes a good question. Is there a minimum number of hours for crisis response? And do you include any in the contract?
Yeah. Yeah. A couple others to ask and think about. How does that provider, the one that goes on site, how do they coordinate with the EAP if there are people they're concerned about, or feedback they want to provide? How connected are they to make sure that once they leave the work site, the EAP is still ready to support them with this personalized need? It could make or break a program in my mind, because employees are going to talk. And when it is an emotionally charged moment, they'll typically go to kind of either end of the emotional spectrum. They're very upset because it didn't go well, or they're very appreciative because it helped them in the moment understand what's going to be coming up for them today, tomorrow, the next few weeks, months, whatever. So it helps them kind of normalize and start thinking about how they're going to be able to accept and move past whatever this traumatic event is that occurs. So it is crucial to be able to understand the importance of a critical incident response type of event, and how employees are going to talk. And rumors about EAPs, again, can make or break a program. So what do you want them to be saying about an EAP after a critical incident has occurred?
Yeah, it's true. They are very high profile events. Important to have them done well.
Well, Zoe, I think we have given our listeners a lot to think about when it comes to sounding like an EAP pro.
Yes, I second that. Thank you for listening. If you do have questions or suggestions for future topics that you'd like to hear more about, we welcome those. Please just reach out to us. And again, thank you all for listening. We look forward to seeing you next time.